lot of my job when I'm in the office is spent trying to explain a heart test. What were they ordering it for? What is the test even designed to look for? And how do you marry that up? The whole point of the provider's job is to kind of marry up the patient with the test and then figure out what to do with that. And that's kind of where the art of medicine comes in. And I find a lot of times patients show up having had a heart test and then are like, well, what did it show? And I'm like, well, who ordered it? Well, so-and-so ordered it. And I'm like, well, what did they say? And then there'll be a big long silence, and they'll be like, well, they told me to come talk to you. So here we are. As you'll see when we go through this, I don't like it when patients get tests done and they don't really know why they were done. What were you looking for? So with that as the backdrop, let's dive into this a little bit. And I think those of you who were here last time, I talked about the different flavors of heart disease, and you can't talk about heart tests without thinking about the different flavors of heart disease. Different tests are ordered for different diseases. So the way I spoke to the group last week is we kind of talked about different contractors for your heart, and subcontractors for your heart. I'm kind of a plumber. I work on blockages. I have some partners who are electricians that work on electrical problems of the heart. There's structural problems of the heart, and there are different diseases of other blood vessels that we work on. So cardiovascular, it kind of goes together. So vascular would imply blood vessel diseases. So peripheral arteries, carotid arteries, and veins. But that's kind of how we think about heart disease in terms of the different flavors of it. And you have to understand that when you're ordering a heart test, because different heart tests look for different flavors of these diseases. Okay? So just keep that in mind. Think about what disease the person is looking for, and that's how they should order the test. It doesn't always work that way, by the way. I mean, I get a lot of patients who get a heart test ordered to look for, that looks at one thing, and then they come to me and say, well, did it show this? And I'll say, well, the test is not even designed to look at that. And they're like, oh, well, that's not what they told me. The most common example I can think of, we'll get into this, is an echocardiogram or an ultrasound. I get asked every day, well, did that show any blockage? Well, that's not what it's designed to look for. So I don't know why you would ask me that question. Did the person who ordered it explain what we were looking for? No. Well, that's why we're in that position. Okay. So this is pretty common. Stress testing. Everybody knows what this is to varying degrees. Stress testing is mostly designed to look for blockage disease. Okay, so we're talking about plumbing disease now. And it starts with a simple EKG, which you should have done before you would do a stress test, because you don't know what kind of stress test to order unless you do an EKG. And I can't tell you how many times things get screwed up because nobody did an EKG, which is a simple, extremely cheap test. You'll find in healthcare that the cheapest tests, or the least expensive tests, get kind of forgotten because there's not a lot of cash to be made off them. But a lot of them are really, really valuable. So I see patients who show up, various places with stress tests, and I'll say, well, they say to the tech, well, what did the EKG look like? Well, they never had one. Well, how in the heck would you order a stress test if you never had an EKG? So you really need to have an EKG to figure out what kind of stress test. And patients always ask me this. Everybody has this kind of view in their head of what a stress test is, and you get on the treadmill and you go, and patients always ask me, well, I've always had the chemical one, so I just want to make sure I get that one again. And I'll say, well, can you walk? Can you exercise? And they'll say, yeah. And I'll say, well, why are they doing it that way? There is no chemical or pharmacologic way of mimicking or repeating exercise. We just don't have it. You know this. You can't find a pill that will make you feel as good as physical activity, right? If anybody's got one, let me know, and we'll get rich. But it doesn't exist, right? So always we would prefer exercise. And when you come here, or a place that has well-trained people running the treadmills, they will always make an attempt. I mean, I have outstanding exercise physiologists that work with me. And if you can walk into the room, they're going to take a stab at it. Now, lots of elderly people maybe haven't been on a treadmill. It feels a little awkward. It's not as easy. I don't know if any of you remember the first time you ever got on a treadmill. It feels a little funky. But if we would prefer that people exercise. And when we look at a stress test, I've said this to some of you who have worked with me, and we get it back. The test is over. You exercised. You exercised as far as you could. You did as much as you could. We monitored your blood pressure. We monitored your EKG, and we monitored your heart rate. And how did you feel? How far did you go? There is buckets of information in that, tons, that gets lost because people just look at the highlights. They don't look at all the details in the stress test. How far did the patient go? What happened to their blood pressure? What happened to their heart rhythm? You can't even diagnose arrhythmias. I put that up here. You can sometimes find electrical problems with the heart. But mostly this is a plumbing disease or a blockage disease test. And there is just tons of information there that is incredibly useful to a discerning cardiologist or a discerning healthcare provider. But you gotta look. You gotta look. Now this test can be done alone with just a treadmill. We just walk you and see how far you go and hook and keep you on an EKG and see what happens. That is a very useful and important test in my world. Okay? Doesn't pay a lot of money, but it's a very, very useful test, and there, like I said, is a lot of information there. Now, for some patients, we need to marry the exercise portion with imaging. So some of you people have heard of an exercise nuclear stress test or an exercise cardio-like stress test. That's just an additional way of getting information from the stress test where we take pictures of your heart before and after exercise and compare them. Okay? So you can imagine what your heart's supposed to do when you exercise. Your heart's supposed to beat more vigorously. It's supposed to get stronger. Okay? You're demanding more of it. So we should be able to see that on the images. Okay? And there's different ways we can take pictures. The nuclear camera is one of those ways. Kind of runs around your heart. We have one here where you can sit in a chair. The other way is to use ultrasound and take those pictures before and after you exercise. So that's an additional layer of information we can get with that imaging beyond just the treadmill. But you don't want to forget about just the treadmill. And this is a mistake I see in everyday practice with, some primary care folks who get stuck on the headline and miss all the data that came with how well the patient exercised, how they feel, what happened, etc. So you really need to look at all that information. And a good cardiologist will look at it all and kind of give the patient an idea about what they think. And in our practice, we kind of lump these things into buckets. No test is perfect here. Let me just say this. I have had many patients who come to see me with a normal stress test who still have all kinds of troubles, and I'm just, we may ignore the stress test. And then I have other patients who come to me with that normal stress test and they feel fine, and we might do nothing. So again, you got to marry the patient with the test. The test doesn't tell me exactly what to do. If it did, my job would be unnecessary. Okay? So take all the information, use it all, and they can make a value decision. And what we tend to do here is tell somebody they're very low risk or they're very high risk with their stress test, or they're in the middle. So stress tests aren't normal and abnormal. It's not black or white. As some of you have heard me say, it's totally normal, holy crap, we got a problem, and everywhere in between, okay? So there's different shades there that, and that, again, it goes back to marrying the test with the patient. Does that make sense? I did point out here that this can be done pharmacologically. You can have a stress test if you can't walk, obviously. Now that one always requires pictures of your heart, always, okay? You can't do that with just an EKG. But the key points here are, this test is mostly looking for blockage disease. We would mostly prefer you try and exercise, and we want to use every little piece of data, because it's all useful. I have lots of patients who every once in a while come back they want to get back on the treadmill. They had heart disease 10 years ago. And we can actually measure how far you can go on a treadmill. So we'll push you as far as you can go. And they'll say, well, how far did I go in 2012? And I'll say 12 mets. And then they'll say, well, how did I do this time? 13 mets. You know, they like that, okay? So it can be used to monitor how a patient's doing clinically over time. But again, mostly looking for blockage, disease, and you don't want to leave any of the data behind. Don't want to leave any of the data behind. Use it all. Any questions about stress tests? Okay. Yeah.
Yeah, a lot of people think stress test covers one thing, but it's like, how many percentage? Like 20% of the whole test. The stress test.
Well,
the rest of the imaging.
Yeah, the imaging ends up getting the highlight, okay? So if you were to get a stress test report, let's say you had a stress test at Aurora and Oscar.
I had it here 3 weeks ago.
Okay, let's say you had one here.
It was great. I mean,
yeah,
it found a lot of stuff.
So the highlight portion that goes in the, you know what I'm saying, if you were to, whenever somebody does a test, or like any kind of imaging exam, like let's say you had a CT of your chest at the hospital, or a CT of your belly, the radiologist, or in this case a cardiologist, whoever's interpreting it, gives an impression, okay? And then there's this big bucket of text in the middle that most providers don't read, right? Okay, they want to look at the highlights. What did this thing show? So when you have a stress test with imaging, the highlights are, what was the imaging? But there's more there. There's more there, and a cardiologist that works with me is gonna give you that other piece of the data, give you the rest, and use the rest of that data. I have had many patients who've had normal pictures, but they couldn't walk from you to me. Now that's not normal, okay? But the highlight, in the primary care, I said, well, your stress test was normal. No, part of it was. So don't forget the rest of the data. So I think, and the biggest thing for me is and my nurses will tell you this, the first thing I want to know is how far did the patient go? How far did they walk? It's such a useful piece of data, and it's so easy to get. 1 met is basically the amount of energy that you're using just sitting watching. And then so we measure that amount of energy you expend on the treadmill based on how far you go. Okay? Yes, sir.
What have you noticed when I was doing this? We used to have a problem with stress testing in women.
Yeah.
Because you get abnormal EKG, but everything was normal.
So this is a really interesting point. So this is a little bit of the art of medicine. So women, as part of their job as the superior gender, for whatever reason, have a more likely chance to have what we call a false positive on an EKG. So I've told you this is not perfect, okay? If I have to know if you have blockages, let me just give you an example. Let's say I have a 45-year-old man who has a terrible heart valve, and he has to have open heart surgery, okay? We have to open his chest to replace the heart valve. Now, that's not a disease of his arteries, it's a disease of his valve. But we're gonna fix it with an open heart operation. I could do a stress test and send him to a heart surgeon. The heart surgeon's gonna call me up and say, what the hell are you doing? I need to know 100% if this person has blockage disease or not. I'm not opening somebody's chest without knowing that for certain. So that patient gets a catheterization, which is the gold standard to look for blockage disease, okay? But now that's invasive. So, you know, you have to accept that there's a tiny risk of that. Even in my hands, tiny risk of it. But we have to know in that situation. So, you know, even if somebody has a normal stress test, we still may take them to the catheterization lab because we're still concerned. So we would say that that patient maybe has a falsely negative stress test. Okay? This is where marrying the clinical story from the patient and the test together is so important. Well, if you took a bunch of women and put them on a treadmill, women tend to have more falsely positive EKG changes when they exercise. So there are changes on your EKG that we look for that tell us, aha, this patient has blockage. Now, it's not 100% accurate, it's a suggestion, okay? But women tend to have more false positive EKGs. So sometimes women will end up with more stress tests with the imaging portion layered on top because the provider might be worried she's gonna have a false positive EKG. Now, how do you do that? So should you order imaging on all women with your stress test? And the answer is no, you don't have to. What you should do is be discerning, like this gentleman, and acknowledge that you know that women are more likely to have false positives. So, but if a woman comes to my office and has a stress test and exercises really well and has no EKG changes, I could be done there. I could be done there. But if she exercises really well and then has EKG changes, I'm gonna know that women tend to have a few more false positives. So maybe we might need to do an additional test where then I'd layer on the imaging portion. My fear of doing, and everybody, any cardiologist worth his salt, fear of that situation is if you do imaging on all women, you're gonna end up, you know, giving some radiation that's not necessary, particularly younger women. So it's a great point, kind of a finer point of stress testing that women can have a few more false positive changes. But there's other tests we can do to make sure we don't falsely diagnose a woman with blockages just because she had an abnormal treadmill. That's a really complicated answer, but hopefully it was a little bit understood. Any other questions about stress tests? Okay. Great test. Just getting on a treadmill is a great test, and it's incredibly cheap. We don't have to go through any prior auths for your insurance to get a plain treadmill. They don't care. Doesn't cost that much, but it's very useful. Okay. Okay, this is the other big money test in cardiology that happens a lot. And these are ultrasounds or echocardiograms. Okay? By far one of the most commonly ordered tests in cardiology in the 10 years here and 2 years in Madison. You know, I mean, the volume of tests with echoes is going just like this. It just keeps going. Just keeps going. And some of that is appropriate, and some of it gets a little crazy. It's one of the most commonly ordered tests in cardiology. It's one of the most poorly understood tests in cardiology. It's again a very, it started as a, you know, I can remember reading ultrasounds years ago, and we'd have like 40, 50 images with one patient. Now we have 70, 80 images with every patient. Easy. So it's a lot, there's a lot there. There's tons of information there. And again, the report, if you get your report, there'll be like an impression or a highlight. What did it show? And then there'll be all this other information down there below it. And a lot of people will just look at the highlight, look at the impression, and say, well, it was normal. Or, you know, but there's more there. And that's why, you know, for those of you who've seen me in the office, you say, well, I was in Arizona and I had an echo down there. We're going to chase that. We're going to go get it. And I'm not talking about the report. We're going to go get the image, the CV image, so we can look at it. Because most heart specialists aren't going to make a decision for a patient based on a piece of paper from another institution. It's just not smart. Like I said, massive amounts of information, but rarely used. It is by far the best way to look at it. It is by far the most efficient and best way to look at the squeeze function of your heart. So we're looking at how well does your heart contract, okay? And some of you who've had heart disease may recognize something called the ejection fraction. That's a big ticket number that everybody will want to know from this test. And that's just the amount of blood that gets ejected with each heartbeat, okay? And we have a normal range and an abnormal range. And so that's a numeric piece of data that comes from this test. It's very important. It's useful for making diagnosis. It's also useful prognostically. The other thing with this is again, by far the best way to assess the valves of the heart. So your heart has 4 valves, 2 of them on the left side, 2 of them on the right side, but the left-sided valves are by far and away the most commonly diseased valves in your heart. And this is the best way to look at those heart valves, okay? And valves do 2 things, right? They have to open and they have to close. And they can do either one of those things wrong, or they can do both those things wrong. So we look at cardiologists to describe valves that don't open right as stenotic. So this is where some of our terms get screwy in patients. So I'll say, well, you have a stenotic valve, and they'll be like, so you mean I have a blockage? No. We're not in your heart arteries now. We're working with your heart valves. So don't get confused here. I didn't say you had blockage. Okay? I said one of your valves isn't working. It's not opening. So we call that stenosis of the valve. And then the other problem is the valves can be leaky or regurgitant. Okay? That's less likely to be confused with blockage. But a lot of my consultations with patients come about because there's an abnormality on my echo. Well, what is it? I don't know. My doctor just told me I should come see you because there's something weird on my echo. And there are some things that should be carefully looked at and should, but there are some things that your heart changes as you get older. So one of the things that happens as you age is your heart has to contract and it has to relax, right? It has to do those 2 things. The heart muscle has to squeeze and then it has to relax and fill with blood. And as you get older, your heart muscle stiffens like the rest of your body, right? Your spine wasn't the same as it was when you were 25. You can't get out of a chair as fast. Your knee is different. Your heart muscle is similar. It doesn't relax as well. And so, in some patients, that's, in a lot of patients, it's just normal. It can be just normal aging. But it takes somebody to carefully look at the images to make that decision. Is this normal aging? Is this a clinical problem? And again, you might actually need to talk to the patient to make that decision. Okay? So this is a real important test. It gets done a lot of places. A lot of places. So I know a couple of the local primary care docs will do echoes in their office. Now they don't interpret them, but they will have somebody scan your heart. I think the big key for me is I want a scan that's done by a cardiac ultrasound specialist. So you probably don't know this, but there's a job, and we have 4 people that do it here, called, an ultrasound tech, okay? So you go to training for this, okay? Now, if you work in a small town, let's say you were out in Wapaka, or, and you went into the hospital there, and they were gonna do an ultrasound of your gallbladder, okay? Because they were worried you had gallbladder disease. A lot of small places will have 1 or 2 ultrasound techs who ultrasound their gallbladder. They might ultrasound your heart. They might ultrasound your pregnant wife. But there is a specialty in terms of being able to acquire images for a cardiac exam. And, we have people here who live and breathe this stuff. That's what they do. They don't ultrasound babies. They don't ultrasound gallbladders. They ultrasound blood vessels, and they ultrasound hearts. So they understand, in some cases, the similar amount of physiology that I do. I mean, they are very intelligent, sharp people. So always my big fear is, an echo is not an echo is not an echo. You want to have your scan done by somebody who does cardiac ultrasound, and that's what they do. So, you have a lot of choices where to get this stuff done. And, I think it's important that you understand, who's doing it. Because whether you have your echo done here, or small town, middle Wisconsin, or Aurora, or anywhere else, you're paying the same for it. I mean, you want to get quality. You want to get a high quality scan. Because people are going to use this to make decisions. People are going to use this to make diagnoses. So, does anybody have any questions about echocardiograms? It's a very commonly ordered test. If you get a little bit sick in the hospital, a little bit short of breath, a little bit, you're probably going to get one. And it's important that we understand the context of when your echo was done too. I get regular consults on somebody who was, had a bloodstream infection and was in shock in the hospital, and we echo their heart. Well, that patient is a different patient when they're sitting in my office. So when they were sick with, a urinary infection in their bloodstream, their heart might look a little different, and I need to know that. So the context of how the patient's doing matters. It matters a lot.
What do you consider a level of ejection fraction where you start to get concerned?
Yeah, so the number. So an ejection fraction is a number that we give patients. Okay? A normal ejection fraction is considered 55 to 65%. Once you hit 50%, we start calling it low normal. Okay? Now, there are some objective measurements we do to look at how well the heart is squeezing. That's what he's asking about, this number that we measure. There are some objective things we do, but there's also the eyeball test that we look at. And for somebody who's looked at thousands of these, you get good at it. So in general, a normal squeeze function, a normal systolic or squeeze function of your heart would be an ejection fraction 55% or greater. Less than that, we would start to call abnormal. And how low it is depends on how abnormal we would call it. Any abnormality on any imaging tests, we always end up with mild, severe, or what's called moderate, which is in the middle, okay? So if you have a mild abnormality or a severe abnormality, that's something that we grade. And that's true for ejection fraction. It's true for diseases of the heart valves. Like a lot of people are walking around with mild aortic stenosis, which is a disease where the aortic valve won't open. Lots of people. Now, we don't have to do anything about that, but it can progress over time. And you would use an echo or an ultrasound to monitor that progression of valve disease. When would it ever go to severe? So, does that answer your question? Okay, good question. Everybody loves the number. Patients who have an abnormal ejection fraction, whenever they come back, if we re-echo them, first question, what's my ejection fraction? They want to know. have to remind them that we take care of a patient, not a number. So I have lots of patients with very poor ejection fractions who play tennis and go jogging. I got some people who have normal ejection fractions who can't walk across this room. So it doesn't tell the whole story, but it is an important prognostic. Okay. I wanted to take a minute to mention CT scanning because this is going to be a little bit different for us here now. We have a really amazing CT scanner here that is ridiculously fast. And historically, CT scanning's been around a long time. I could take a CT scan of your liver, no problem. I could lay you on a table and just say, hold still, right? And your liver's not gonna move. But what if we did the same thing and said, all right, tell your heart to stop beating for about 10 seconds while I apply the scan. It doesn't work, right? You can't do that even if you try. So for years and years and years, people have talked about trying to do CT scans of the heart, but it's a beating thing. And the blood vessels of the heart are kind of small, and the CT scanners weren't fast enough. And so people would try and take a CT scan, and it would look like a blurry mess. So then you did a CT scan for nothing, right? Well, that's changed. That's different. Now, this is not a test for everybody, but it is a test that we can selectively utilize in people where we're worried about blockages of their heart arteries. We can take a scan of your heart, and in one beat, we can acquire pictures that will show us your heart arteries with clarity that would blow your mind. Now, you don't want, you need to know who to order this on. This is not a test your primary care doc would order. This is not a test typically that a lot of ER docs would order. A lot of ER docs would like to order it, and they have. We've tried it. I've had some of the Theta Care ER docs call me. You think we could get a CT scan of this patient? You think it would work? There's a couple key elements that we have to know. Like if you come in and your heart rate's 130, do you think I'm going to get a good CT scan of your heart? No. Okay, so don't even waste your money. Don't waste the patient's money. Let's not waste everybody's time. It's going to be a garbage scan, so don't do it. You need to have a nice slow heart rate. And sometimes we'll even give people medicine to slow their heart rate down before the scan. So if any of you have ever had one, we'll give you some medicine to slow your heart rate down the morning of the test. So my techs can time the acquisition of the scan with when your heart is relaxed. That's what they want to do. So think about that. We're talking about milliseconds here, right? 60 beats per minute, 50 beats per minute, okay? We need to acquire a CT scan quickly while your heart is relaxed. That's when you get the best images. So they'll actually gate the CT scan with your heartbeats, okay? So, and then they know when to acquire in between the heartbeat. That's how amazing this is. And the pictures are again, now imagine if we had a patient who had, premature beats every third beat, boom, boom, and then a premature, again, it's not a good patient for this. We don't want to miss, we don't want the heart to beat right in the middle of the acquisition. But this can be a very good test to look for blockages with the same, and I put catheters in people for a living, and some of these scans can show detail that even impresses me. Because catheters work so well because I can park them right in your artery and take pictures. And acquire really good images. That's the gold standard for blockage disease. But this is getting there. It's getting there. And we've had several patients come through here now. One of them a couple weeks ago who had a CT here, and he had been having chest pain for a couple weeks, and he had a normal stress test. So let me take you back now. Normal stress test, but I don't feel good. So again, you gotta marry the patient with the test. Don't just sit and tell somebody that their stress test is normal. I don't know what you're talking about, you don't have any problems. So have to talk to the patient. So, he and my partner said, you know what, I think we're gonna do a CT scan of your heart. I'm still kind of worried. So we did a CT scan of his heart, and he had a 70–80% blockage in one of his heart arteries. He showed up to see me for a catheterization, and he told me, he's like, you know where they told me where the blockage is already, so go ahead and fix it. I said, well, you know, this is the gold standard. What I do is the gold standard. The CT's not perfect. Well, damn, that thing was perfect. It's told me exactly the same information I got. We put a stent in. He was very satisfied. So, I mean, you can get really exquisite detail, but again, you need proper equipment, and what I mean by that, you need a fast CT scan, okay? And you need the proper staff, the proper protocol. So again, the CT techs that work here, this is what they do. They do these kinds of things every day. You go try and do one of these on a CT scanner sitting in the emergency room where they're doing, you know, bellies and brains all day long. I mean, a CT tech is not a CT tech is not a CT tech. It's like a doctor. You wouldn't go see me because you want a new knee, okay? That would be silly, okay? Are me and the orthopedist both doctors? Yes. But we have different specialties. So a CT tech who works here with people who take pictures of blood vessels all day knows how to acquire the right images. The only other thing I wanted to mention about CT scans that we're using them a lot more, and I wasn't planning on talking about this, but we can if people have questions. Transcatheter valve procedures are becoming more common, much more common for patients with valvular heart disease, so diseases of the heart valve, that we don't have to fix them anymore by opening your chest. We can actually do it on catheters through your groin sites. And these CT scans have become a big part of that. I can tell you our group has, you know, participated in a couple hundred transcatheter aortic valve procedures, and the CT scans are invaluable, invaluable. They give us tons of information. So you do not get to lay on the table for a transcatheter valve procedure until we've gotten a high quality CT scan. And again, proper staff, proper equipment, proper acquisition. Okay? You can look at blood vessels in other places. So you can look at the blood vessels of your heart. Sometimes we look at the blood vessels of people's legs. Sometimes we look at the blood vessels of people's brains. You can imagine the same blockage disease that comes here can come here, or here, or here. We use the CT scanner to look all over for blockage disease, okay? It is, in general, a little bit easier to take pictures of the leg arteries and that kind of thing, because you can just tell the patient to hold their leg still, okay? But, again, we can't do that with the heart. Anyway, CT scanner. And like I said, I think ours may be the fastest in the state. It is, I think, one of two around here that's 256 slice. So I mean, it will, and the radiation dose is substantially less than what people use. Okay.
How fast was the one, I had a CT of the heart back in 2006.
Yeah, that would have been a 64 slice.
And they made an issue because I have atrial fibrillation,
Yeah.
and I had to take a lot of
Raise
beta
the
blocker.
Yeah. So he's talking about, he had an arrhythmia,
You know,
and sometimes that can cause your heart to beat in an irregular way. So if you can imagine, if you're the CT tech and you're trying to time that acquisition, you want those heartbeats to be regular, so you know when to pull the trigger. But it makes it more difficult. So they gave him extra medicine to slow him way down, so that when they did the CT scan, they could get useful information. But 2006, that CT scan.
Today, no problem.
Today, yeah, we would be doing even better today. Yeah, 64 slice CT scanner, you're not going to be able to. No one's going to want to buy that if you're selling it. It's like a really old used car. Yeah, no, this CT scanner we have now is pretty impressive. But more so, it's the people doing it. I mean, it really is. I mean, you've got to know what you're doing here. like you said, you gotta know to get that heart rhythm slowed down and regular. So I want to transition for a minute to some of the electrical diseases. So we talked about plumbing diseases, we talked a little bit about structural diseases with the echo. So other tests that people get, and a lot of these are to look for arrhythmias. So one of the most common reasons people come to my office is, I feel my heart beating funny, I feel it skip, I feel it go fast, or maybe they think it's too slow, maybe they're passing out, maybe they're lightheaded all the time. So it always brings up the quandary, is there an arrhythmia going on? And you can imagine, it's very simple, either the heart's going too slow or it's going too fast. Those are the two flavors of arrhythmias, okay? And 99% of the time, if you're having trouble, it is not going to happen in my office, right? It's just not, because when you come here, you feel better. And then, you know, when you go to your primary care doctor for your cold, your symptoms are getting better. So this can be a struggle. Obviously, we can do an EKG right at that moment, see what's going on, is there anything suggestive? But if you're not having the symptoms, then we're stuck, okay? Well, I feel fine now, but where were you on Friday night when I had this trouble? So we have all kinds of monitoring devices for this, and this has changed. And you probably read in the lay press about the Apple Watch and the new app you can get with that to monitor your heart rhythm. I mean, where this is going to be in 5 years, 10 years, I don't know. Right now, you know, monitoring devices through a watch or an app, I'm very reticent to give somebody a diagnosis based on any of that stuff. I mean, if we give you an arrhythmia diagnosis, it matters. I mean, we don't want to hand these out like candy. If you have a problem, we want to acknowledge it, but if you don't want to hang that around your neck. So I'm a little reluctant yet to use that, and there's no good data supporting it yet. But I think 5, 10 years from now, we may be looking at it. What we have today are a couple things. We have what's called a Holter monitor, which has been around for a long time. And this will record every beat of your heart for 48 hours, okay? So I can give it to you, and you can wear it for a day or 2 days, but that's it. So it's helpful if you're having symptoms every day. But if it only happens once a month, I guarantee you I'm going to give you a Holter, and you're going to feel great when you're wearing the Holter. And then when you bring it back, like, damn, it came right back. We're going to struggle. So you got to know who to order a Holter on. Make sure you know, primary care docs call me all the time. Well, he's been having palpitations. I already did a Holter. It's normal. Well, how frequent were the palpitations? Well, he has them like once every 6 weeks. I said, well, you know, what are you going to do? I mean, you're not going to catch it. Unlikely. You can still try. We have other things called mobile cardiac telemetry, which are similar to Holter monitors, but can go longer. Okay? Can go longer, up to 7 days. Okay? And we even have event recorders that are like mobile cardiac telemetry that you can keep for 30 days. Okay? So now you're talking a month. Now, those devices don't record every beat of your heart. If they had to record every beat of your heart, you'd be carrying around a small computer in your pocket. But they don't. They monitor, we program them to monitor for certain arrhythmias, and then you tell us when you feel something. So you can kind of activate it and say, I don't feel good. My heart's racing now. Or I'm lightheaded, I'm going to pass out. The device will collect your rhythm at that moment and tell us what's happening. So we have to order the right one based on how frequent your symptoms are. The other one that has come around in the last year is called an implantable loop recorder, and I wish I had one. It's about the size of this cap, but it's actually a little bit thinner. And we actually put them in under your skin. It's like a little capsule, and it goes right in under your skin. And that thing parks there for a couple of years. And it collects all this data. And it notifies us when you're having troubles, and you can tell us, hey, on Saturday at 4:30, I felt terrible. My heart was racing away at me. What was going on? And then we can go in and look, and the device will tell us. It will tell us. So these are really cool. We just started implanting them here in our office. I mean, you'd be blown away if you saw one. It's just under the skin. There's not even really any stitch. We just use a little glue, and then it sits in there. Now you got to come back and get it checked every so often. But you know, it can be a very useful test, a useful tool, I should say, for people who struggled with, we can't catch it. And then finally we give them one of these, and we just say, come back when it happens, you know, and they do. Monitoring devices are mostly for electrical diseases, but you want to pick the right monitoring device based on how often the patients have them. Okay. I put something in here about tilt table testing. Some of you may have heard of it. It's kind of an unusual test where we flip you upside down to see how your body responds to kind of changes in your position. It's something we use very common, something we sometimes use for people who have what's called vasovagal symptoms or vasovagal syncope, which is just a misfiring reflex. You can imagine if you're standing up, your heart and your brain, your brain's above your heart, and then if you lay down, they go back kind of more even with one another, so blood flows, doesn't have to fight gravity. Well, your brain and your heart communicate all this. You don't have to think about any of this when you stand up. You don't have to say, all right, I'm gonna stand up now. Brain, just be prepared because, you know, the blood's gonna have to fight gravity now, so my blood vessel's gotta squeeze a little more. You don't think about it, it just happens on a reflex. Well, sometimes that reflex gets screwed up and it misfires. And a tilt table is a way to see if is it that reflex that's misfiring. But we do use it for people with passing out or who have recurrent lightheadedness sometimes. More often it's younger women. I don't know why, but younger women tend to have that type of problem a little bit more. We do have a tilt table here that we will use, so I wanted to mention it. It's not a super common test. Occasionally ordered by neurologists, rarely by primary care doctors, mostly by us. Any questions about the electrical monitors? Okay, so calcium score. This is another big ticket item. And I talked about the CT scanner before. This doesn't require a fancy CT scanner. It does not. Let me say that again. This does not require a fancy CT scan. Okay. This is a different kind of test. We're not taking a super fast picture of all the blood vessels of your heart. We're just taking a few images of your heart arteries to see if there's calcium in them. Okay? We're not going to tell you if there's blockages. This does not tell you if there's blockages. It just tells us if there's plaque in your heart arteries. Okay? That's a very common misconception. And you will find that you can get a calcium score a lot of different places. You will also find that in general your insurance company will not cover it. And in general you will find that it costs very little to have it done. So most places charge about $50 for a calcium score. We charge 25. We can't run that through your insurance. They're just not going to cover it. But the big question isn't how it's done, but the big question is who should have it. Because a lot of people ask me, should I get a calcium score? So the short answer to who should have it is definitely not people who've already had heart disease.
Not people what?
Who've already had heart disease. So if you come to me and you want to establish care and you had a stent 10 years ago and you say, I just moved to the area, what do you think about this calcium score thing? What are you talking about? The horse has left the barn. We already know you have heart disease, okay? I don't need a calcium score. Keep your $25, okay? So if you've had bypass surgery or stent, I just look at people that come and say, well, I'm going to get another calcium. What? No, don't do it. If you want to give me $25, just give me $25. Don't do this. So if you have known coronary artery disease, if you have known blockage disease, this is not a necessary test, okay? This is not a necessary test.
Can you have blockage and still have normal calcium score?
Great question. The answer to that is yes, but not very often. It's very, very uncommon, but it can happen. So the calcium score is looking for calcium in your heart arteries, and if there's calcium, it means there's plaque, okay? Now, the calcium score doesn't tell us that the plaque is limiting blood flow. It could be just, if this is your heart artery, it could be just a minor plaque like that, okay? The calcium score does not tell us that. It just tells us you have plaque. So who is this most useful in? It is most useful in those people who are unsure if they should take a cholesterol medicine. Okay? So let's say, I'll give you an example. I think I gave this last week. My brother is 41. He has an LDL cholesterol of 125 or something like that. He's very active, very healthy. But his doctor's like, I really don't like your LDL cholesterol. It's a little too high. I was like, well, I'm doing the best I can here, I exercise a lot, I eat pretty good. He's like, well, I still think you should go on a cholesterol medicine. My brother's like, geez, I'm 41. I want to be on medicine for the next 40 years, right? I don't have heart disease. Why are you lumping me in with all those people? So I said, he called me and I said, listen, you should just get a calcium score, okay? So he comes up here, gets a calcium score at 0, brings it back to his doctor. He's like, I'm not taking a cholesterol medicine. It's a very good way to utilize a calcium score. Protect yourself from doctors giving you too many meds. Okay? So that's a good person to use a calcium score in. Somebody who we're unsure of if we should treat their cholesterol more aggressively. So let's say my brother came back and his calcium score was 400. What would I recommend then? I would say his lifetime risk of getting heart disease is high. I think we should treat his cholesterol more aggressively. I would consider putting him on medicine in that situation. Does that make sense? Okay. So I get a lot of people who come in and say, well, I had a calcium score, it's kind of high. What do you think I should do? I'll say, well, what's your cholesterol? And they'll be like, well, it's kind of high, but I really don't want to take any medicine. I'm like, why the hell did you get the calcium score then? If you already decided you're not taking any medicine, keep the 25 bucks, keep the 50 bucks. If you don't want to know, if ignorance is bliss, then don't get the test. But if you want a good idea about what's your future risk of heart disease, this can be a very useful test. And it is, numerically important. 0 is normal. 0 is normal. If it's above 0, it's not normal. So 2 is abnormal. Now, if you're 4,000 and 2, is there a difference? Yes. But you still technically have calcium in your heart arteries, and there is plaque there.
What is the benefit to a patient to have an overread on this particular test?
So one of the things we offer is an overread. And all that is we have a radiologist look at the rest of you. So like a radiologist will look at your lungs, a radiologist would look at your bones and the other structures in your chest. We don't routinely look at those. So a lot of places will charge, like we charge 25 bucks for a calcium score, and then if you want an overread, it's another 25 bucks. So technically it's 50. Most other places, it's 50 plus another 25 for the overread. Should you get an overread? You can. I mean, if you ever smoked in your life, I'd probably get an overread, just to make sure you don't have anything in your lungs that would, worry somebody. But if you never smoked, you probably not necessarily get an overread. But if somebody's going to take a picture in there, having a radiologist eyeball is not that big a deal. Particularly if it's only cost me 25 bucks. But make a plan for how you're going to utilize the test before you go do it. Just have some thoughts, okay? I had a guy come in today who said, my church is having a Lifeline fest. You have any heard of Lifeline? Okay, so If you go to church, these people will pray on you at church, okay? So Lifeline is a company that will come in and do screening tests for vascular disease, okay? So they will do ultrasounds of your neck arteries. They'll do blood pressure test of your legs to check for blockage. They'll do an ultrasound of your belly to look for an aneurysm. And they'll do like blood pressure and EKG and stuff. And that'll be like $100. And then they'll give you a piece of paper and say, here's your results. And then they'll say, and if it says abnormal on it, which sometimes it does, the patients say, well, what should I do now? I'll say, go see your doctor. So I don't like Lifeline, okay? Because keep your money. Don't do it. If you want to have a vascular screen, come here, we'll do it. We do that too for $75. Again, it's not for everybody, but there are definitely patients who benefit from this. But my biggest problem with Lifeline, and the patient today asked me, so, well, why don't you like this? I said, well, what if this is abnormal, right? Any doctor worth his salt is going to want to say, well, I don't want to look at that image. Remember I told you if you have an echo done in Arizona, I don't want just the report, I want the picture. I want to see it with my own eyes. So I'll call Lifeline and say, hey, I'd like to see that scan on Mr. Jones that you did of his carotid arteries. No, sorry. Then I got, well, you said it was abnormal. Yes, we did. Now what? Well, I got to order another scan to get the diagnosis. So if you want to get a screening test for heart disease or vascular disease, just don't do it through a company like that because there's no follow-through. And then usually what they'll do is say it was a little bit abnormal, make sure you come back next year when we come through again. And I'm like, well, what are you doing here? Like you just want the, we better recheck it. Well, you told me it was abnormal, how bad? It's bad enough we should recheck it, so I don't like it. So if you're gonna do screening tests for heart disease, don't do it through the local salesman at your church. Do it through a place where they're gonna help you with your test results.
So you're saying if you have screening done by outside people such as this, they, even if you signed a release, they would not send the results?
I have tried to get images from those companies and I have not, the actual images. The results I can get.
No, I'm talking about the images.
The images. I have not had any luck getting actual ultrasound images.
That's interesting. Okay.
Now they do give you like ABIs images, so like ABIs are ankle brachial indices. Those are tests of your legs to look for blockage. They'll show the pressure measurements of your legs, which can be helpful. But if I want to look at the image of your carotid arteries, and remember, they'll do what's called just like a 2D or a B mode ultrasound of your carotid artery. They might measure a velocity, but there's a way to do that. There's a careful way to do that at a certain angle, and positioning your sample volume in the right spot in the artery. That's an art form. So again, somebody who does that every day. So I don't not like those companies just because they won't give me the images. More of my problem is the fact that they hand this to you and then say, now go talk to your doctor.
Yeah,
And then your doctor didn't order that test.
yeah, exactly.
So now he or she's got to explain it. And you're like, well, so if you have a conversation with somebody like me or your primary care doctor or another heart and vascular specialist, you say, hey, I'm thinking about having this screening test. Okay, I think you're a good candidate. If one of my patients who, I have a procedure on a guy's leg tomorrow, we're going to work on a blockage in his leg. If he came to me and said, Lifeline's coming to my church, do you think I should? No, I know you got blockages down here. You're not telling me anything I don't know. So keep your $100. But I guarantee you, if he went and said, oh, I'm here, yeah, maybe I should get this, they'll say, sure, come on in. They're not going to say, have you ever had a blockage problem? Or have you ever do they know you have an aneurysm? They're not going to ask you. They're just going to do the test. And then they're going to collect your money.
There's no history.
It's not a good way of practice, I don't think. Now, there are stories of patients who had problems found and felt like they benefited. I'm not gonna argue that. But to just, routinely, spray all over your, patient population. And you know why they're going to church, right? Who goes to church? Right? Old people? Okay. Yeah, I mean, that's the reality, right?
Well, what about
That's
those,
true.
what about those coupons you were giving out down here?
So, yeah, so it's a good question. It's a good question. I mean, should everybody have that test?
Yeah.
And I think the answer to that is no. Now, do we give coupons for it? Yes. But that doesn't mean you should have it. It means you should have a conversation with somebody about having it, or a conversation with your primary care doctor. But if you already have peripheral artery disease, and you've had stents of your legs, I would say, why would you get that test?
But if you've never had it done,
If you've never had it done, I think it's very reasonable.
okay.
But, again, you don't want to just get the piece of paper back and then say, best wishes. You know what I'm saying?
Yes.
And that's where I have a problem. Or, the other one that I see all the time is, I had a calcium score, it was 400 2 years ago. Should I get another one? No. We wouldn't do that here.
Uh-huh.
We've had people come here, that are very young, like in their 30s, and say, I'm here for my calcium score. Particularly a young woman, non-smoker. No, we've turned them away. We're not gonna do this on you. You're too young, we're not gonna, so we don't, these screening tests aren't meant to just be randomly sprayed across the whole
It's
population.
in conjunction with something.
Yes, in general it is.
Okay.
So if you go down and read the brochure on the calcium score, it talks about the ages of people that we do it in. I mean, you can't bring your 10-year-old in here and have a calcium score. We're not gonna do it. Even if you pay us money, we're not gonna do it.
Okay.
Does that make sense?
Thank you.
And I think by doing your screening test at a place like this, we give you a mechanism to figure out what it means. So am I gonna turn a patient away who's 50 years old and walks in and says, I really want a calcium score, I want to understand more about my disease risk of my heart? No, I'm not. We'll take your $25 and do it. But we're gonna give you a mechanism to figure out what to do with the result.
Okay.
So, okay, was it high? Yeah, it was. Now what? Well, why don't you come in and talk to us? Let's figure this out together. Not just,
Send you home.
go see your doctor and thanks for the $25. That's my problem with the
Yeah.
screening programs that are done in churches. Okay. Ultrasound, this kind of dovetails a little bit into some of her questions. Again, it's a very good way to look at diseases of the arteries and veins in your body. So again, we have special vascular ultrasound techs who look at this. They look at your neck arteries, they look at the veins of your legs, they look at the arteries of your legs. And it's a very excellent way to assess all these things. It's simple, it's non-invasive, and it's very reproducible in capable hands. Very reproducible in capable hands. So again, you want to have it done by the right people in the right place. So just to kind of throw a couple conclusions out there, don't order a test without asking a question. So if you're ordering a test, generally the clinician wants to have a question in their mind. How am I going to use this test? What am I going to do with it? Make a plan. Don't let your provider just bully you and say, you need this, this, and this. Maybe you don't, okay? Ask for the test report. What does this mean? What did it show? You can, and if you're a patient of mine and you get something done somewhere else, I'm gonna say, I need a copy of the images. I want you to sign a release, and my staff will chase that down. And I get a CD back, which stinks, but it's the way of the world right now. Unfortunately, not all the electronic health records across the world connect with one another. Maybe someday. If it's a cardiology test, ask if you should see a cardiologist. What did the test show? Was it abnormal? You know, if it was, do I need to see a cardiologist? And if you ask, you should come here. Yeah, just try and be, this is sometimes not easy because being a discerning patient, you know, sometimes providers get impatient with that. Don't want to answer too many questions, but it's your test. I mean, so you have every right to know why you're doing it and where to show. So that's if you walk away with nothing else tonight, that's a big part of the take home point. That's true whether they're taking care of your lungs, your heart, your kidneys, or your gallbladder, or whatever. All right. That I will conclude, unless any of you have any questions or through a lot actually.
How long have you been here?
Here, in this building?
No,
Oh, in Fox Cities?
Yeah.
2008.
2008.
Yeah. I was in Madison for a couple of years, and that's where I did most of my training, and then I came up here. So, yeah, I'll be 11 years. Yes, ma'am.
You talk about people giving tests that aren't qualified, but they're more, the specialists are more qualified, that have qualified people to give the tests. What happens if I go to the hospital with this suspect of some kind of heart problem? We run the test there. How do I know that they're?
I mean, you're not always gonna know, right? If you're sick and you're in the hospital, I mean, it's not like you can get up and walk out. I mean, you could. But, maybe you belong there for a reason, and there are certain tests that, you know, we mostly do in hospitals, right? But I think, in general, you want to feel some level of comfort with the person taking care of you, where they're explaining what the test showed, how they're going to use it, what we're going to do differently, what medication we're going to start, what procedure we're going to do, what we need to do next. How did we use this piece of information? And if you can't get that answered, then yeah, I would say then I would ask for another opinion. It's going to be hard for you in the inpatient side of the world to be super discerning in terms of, you know, what test was this? Was it done by a qualified person? But in the outpatient world, you can pick. You can pick. And, you know, if you're going to have heart trouble, we'd love to pick here. But that's a fair question. I don't have a perfect answer. But you got to go somewhere where you trust. The good news for, you know, I mean, our new situation is kind of different now because, you know, my patients always ask me, well, what's going to happen? You know, I'm in the hospital. Well, nothing. I'll still come see you. I'll come take care of you. I mean, I was in the hospital all day yesterday. So we're still in the hospital. We're in Theta Care's hospitals. I was over at St. Elizabeth's today. So if you know, one of the benefits of being our own group is, you know, I've had a couple patients who through the years have been somewhere else for inpatient care, and they're like, well, I asked for you, but you know, you're not there. Well, that's all. We're going to change all that now. So I don't care if you're at St. Elizabeth's, Theta Care Appleton, Theta Care Nina, Oshkosh, Aurora, you know, Mercy, Oshkosh. We'll come find you. We'll come find you. But you just gotta say, hey, this is my cardiologist. Or this is who I want to see. But yeah, it's tough. You know, that's tough. And, you know, when I go see a patient in the hospital, no matter where it is, I'm gonna look at the images that they acquired in the hospital and overread them. Even though, you know, we don't, you know, somebody may have interpreted that test already. But like I said, I don't care what their interpretation was. I gotta look at it with my own eyes. I'm not gonna take somebody else's word for it. So we would re-look at your information for you. Yeah. Thank you.